Good morning, class. I'm here to talk to you about Lesson 2, the communication, delivery, and treatment of mental health care. And we're going to be doing chapters 2, 4, 5, and 7 from your book. Chapter 2 is the delivery of mental health care, and we start with the historical component of mental health care. And you know me, I love history, although the history of mental health care is not a pretty one. Early civilizations thought that anybody who had bizarre behavior needed to be isolated. So you saw asylums popping up for people who had mental health issues, for people who were prisoners, for people who were even orphans. And they were known for their cruel and inhumane treatment. The 17th century especially is noted for its most horrific and lowest standards of care. You did not want to have a mental health condition in the 17th century. Change began happening in the late 18th to early 19th century. And three particular historic figures I'm going to talk about and your book discusses. The first one is Benjamin Rush. He was a physician. He was also a signer of the Declaration of Independence. And he noted that you needed to provide clean facilities and you needed to provide good food, but also that kindness led to improved interaction and had curative effects, and that had an effect on caring for those with mental health issues. Dorothea Dix was a school teacher, and she exposed conditions and provoked legislation for mental hospitals to have standards of care. She was one of our pioneering people in the mental health field. And then last but not least is a nurse, Linda Richards. Linda Richards was born in 1841 and died in 1930, and she was a pioneer as the first trained nurse in America. She trained under Nightingale. She came back from Europe and established nursing schools, training schools in Boston particularly. In 1882, she opened the Boston City Hospital Training School for Nurses and had a specialty for training nurses to care for those that were considered mentally ill. It was not until 1913, however, that the first psychiatric content was included within the curriculum of an actual nursing school. In the 20th century, we saw a bunch of different legislation. The National Mental Health Act of 1946 was the first legislation to provide funds for research, advanced nursing degrees, and improved community service for individuals with mental illness. We saw in 1949 that the National Institutes of Mental Health was established in support of continued research in the field of mental illness. And then in 1953, the National League of Nursing included psychiatric nursing in all of its nursing programs. And that is one reason why, as an accredited program that you're going to, you're having this psychiatric content included in your nursing school as well. The other thing that happened was the introduction of medications to help with mental health care. We first saw, before medications were introduced, we saw restraints being used all the time. We saw surgeries like lobotomies being done. Sedatives were developed that helped starting to calm people down a little bit. But then we saw lithium being utilized as a mood stabilizer. In 1956, then we had the first psychotropic drugs, antipsychotic drugs that were used to control some of the bizarre behaviors of people with psychotic events, people who had schizophrenia and things like that. And soon after, then we saw the development of antidepressants and anti-anxiety meds. As a result of the development of these medications, then we saw a deinstitutionalization of patients from hospitals and asylums, and being able to be taking part in all walks of life and in the community itself. So then there was a need for community outreach programs. So You had a big rise in community counseling and outpatient therapies as a result. But the onset of those antipsychotic meds and antidepressants and things like that really helped deinstitutionalize a lot of people. Some other federal legislation that we needed to see happen was the Omnibus Budget Reform Act, which placed restrictions on nursing home placements of people with mental health issues. The Mental Health Act of 1983 provided patient rights. Mental Health Parity and Addictions Act of 2008 improved insurance benefits for mental health care. And the American Disabilities Act was the federal civil rights law that prohibits discrimination against people with mental disabilities. The Patient Protection and Affordable Care Act created a mandate benefit for insurance coverage for mental health and substance abuse disorders. And then the Mental Health Reform Act of 2016 tried to improve enforcement of the other acts. So what are some current issues in mental health care? One of the big ones is access to care. And it can be related to cultural disparities. Some cultures would prefer to have, people go and utilize folk remedies and family remedies and not seek a professional for mental health care. They want to keep it private. Some may also think of it as a spiritual thing and want to seek a spiritual advisor instead of a mental health professional. There can also be a lack of access to care with people in certain groups, and we need to think about, especially since we've seen in research, people who are lower socioeconomic status, lower educational levels, and limited income. They have enough going on with that, but the stress related to that causes an increased risk for mental health issues, but also creates a problem and a barrier to get access to care for those issues. If you don't have a job that has good insurance, then you might not going to be able to afford to go and get mental health care or get the prescription that's needed to control your mental condition. So that may be an issue for some people. And then the other groups are people who experience racial and cultural bias and stereotyping from mental health workers themselves. So we have to be super vigilant and cautious that we are not part of that problem. And that is one reason why I had to do that bias paper in level 3, to think about that. Your book talks about some of the things that some of our immigrants go through. There's statistics show that the younger an immigrant is on arrival to our country, the higher the incidence of psychiatric disorders. And then the older, the less incidence. There may be a lot of factors that tie into that, whether or not the cultural shock, maybe a separation from family members or whatnot, can lay some of the issues related to those statistics. And then the cultural unpreparedness within the system is another issue. Sometimes we're not really aware of what is considered a psychiatric or a mental health issue in one culture may not be considered a mental health issue in another culture. Some cultures outside of the United States may consider something a mental health issue where we actually would consider it a physical issue. Examples, in some countries or some cultures, headaches and seizures we consider as a physical issue, but that's considered more of a mind or a mental health issue in another culture. So be aware of that. And then your book talks about costs of care and gets into some of the insurance legislation that I already talked about. Some legal and ethical considerations. Know what the definition of ethics is. And then know what the patient's client rights are. You've learned all about that in the program already, but this is especially important with our patients in a mental health facility. And there's a nice listing of the patient bill of rights there on page 24. Informed consent is also another issue that you've already learned about, so read over that. But patients with mental health issues also need to have informed consent. And then, of course, confidentiality is huge in mental health care. There is a good chance that you may meet somebody in a clinical setting that you would know, whether it's a psych setting or an addiction setting, and you need to be well aware of the fact that HIPAA is especially important for maintaining that privacy of that individual as they are seeking to get healthy and improve their well-being. Box 2.1, there's a nice legal guide to decision-making capability listed there on page 25. And then client teaching notes, topics for clients to discuss with a mental health professional. Make sure you know what your role is, and make sure we are providing the kind of care that a patient should be getting teaching-wise. Now, I talked about confidentiality being a big issue. There are moments when we are required to disclose information, and that would be that's listed in your PowerPoint: an intent to commit a crime, duty to warn endangered individuals, evidence of child abuse, initiation of involuntary hospitalization, which we'll talk more about coming up here, and then infection by HIV. There is an appeals and complaints process, and people with mental health issues also have that right. They need to know how to file a complaint and how to file an appeal. Use of seclusion and restraints, we talked about a lot previously. Make sure you have a good understanding of that, because that's a big deal in mental health care as well. It is regulated by JCAHO and the federal government, and we use it only when all other options are exhausted. And it requires mandatory continuous observation, because patients can really be affected in a variety of ways if we're not doing that. And then accreditation and legal issues can result if you don't follow that. Know what seclusion is, know what a physical restraint is, and what a chemical restraint is. And then our accountability in providing care. We have personal responsibility for our actions. We have to maintain current licensure and education requirements. We have to have knowledge of the institution and government policies. We are liable for incompetent or negligent care. We have to provide accurate and appropriate documentation of care and events, and we have a legal and ethical responsibility to advocate for our clients. So we have a lot of ethical and legal issues that we need to be thinking about when we're providing care as well. So some practice settings for mental health care. The one you want to think about when we think about providing care for somebody, we want to have the least restrictive environment that they need. We want them to get the care they need, obviously, but we don't want to restrict them unnecessarily. So you consider the client's history and the factors that led to the current admission that they have. So the first one we think about is the inpatient psych setting. You can have a voluntary admission, a voluntary commitment, which we consider a 201. And then you could have an involuntary commitment, which we often refer to as a 302. There are other numbers that we give to different types of commitments for longer days and different scenarios. And we'll talk more about that when we get into the actual clinical component. But just be aware that anybody who even goes in voluntarily has a right to file a 72-hour notice saying they want discharged. And then that 72 hours gives the facility and the medical staff the ability to determine whether or not they're safe enough to be discharged. And if they're not safe to be discharged and they still want to be discharged, then it is the facility's responsibility then to get a court proceeding for involuntary commitment. So it takes a court to determine whether or not an actual legal proceeding to determine if a patient should be involuntarily committed. We also have outpatient mental health care settings, and that can include a community mental health center, a social service agency, a private clinic, a facility with multiple outpatient treatment options. And then you have non-psychiatric healthcare facilities. Think about just the fact that you could be providing mental health care no matter what type of nursing you're going into. I'm sure many of you who did med-surg clinicals might have had patients with mental health diagnoses. So just be aware those would be considered non-psychiatric facilities. You could have outpatient health settings like doctor's offices. You have people who experience powerlessness, grief, and insecurity in a variety of different ways. I think of not necessarily a psychiatric service, but last fall when I went to a grief support group, that provided a non-psychiatric outpatient community service that dealt with a mental health issue. Acute care settings for clients who are dual diagnosed, I mentioned that already. And then correctional facilities are another big place where you'll see people that have a mental health diagnoses. So treatment of mental illness is chapter 4. You want to first establish a therapeutic milieu, and that is a safe and secure structured environment where you have therapeutic interaction between the client and the staff. And the goal is to reach a goal. And so we want to have an environment that feels safe for the patient. So you want to have rooms that have lighting and have an opportunity for the patient to experience sun and outdoor enjoyment if possibility. You want to have an environment where there may be some downtime and some games and some organized activities that can be fun. But then you also want to have activities that are goal-directed, group therapies, individual therapies, and things like that. So establishing a good therapeutic milieu is very important. Who is responsible for doing that? Everybody who's on the treatment team, and that includes the psychiatrist, the clinical psychologist, the psych nurse, mental health technician, social worker, licensed professional counselor, case manager and outreach worker, religious counselor, therapeutic recreation specialist, occupational therapist, dietitian, the list goes on and on. So there's a lot of people that help out with that. So the role of the nurse. We talked about the role of nurse in a variety of different ways in past levels. The role of the nurse in this level is counselor, educator, advocate, and caregiver. We do all of those things. So the types of therapy. On page 60. Psychotherapy is a dialogue between a mental health practitioner and a client with the goal of reducing symptoms. And there's a number of ways that we can do psychotherapy. And if we were able to be together in class, I would have put you in groups and we would have researched different types of psychotherapies. But we're going to just review it a little bit in here on this video today, and then I'll have you talk about it in some of your assignments. Telemental health is also a form of telehealth, and you've learned about that in previous levels, but using a web camera based intervention. We're probably seeing a lot of that going on with the pandemic right now, even with regular physician office visits for a family practitioner. They're probably doing a lot of Zoom calls. There's probably a lot of telemental health going on today right now. So what is some individualized psychotherapy? You have the psychodynamic therapy, and that is basically assuming the client has insight into early relationships and their experiences, and that is a source of what some of their problems are stemming from, and that can be resolved. So psychodynamic therapy. Humanistic therapy centers on the client's view of the world and his or her problems, and the goal is to foster a sense of self-worth. And so it's not really it's basically focusing on helping the client to explore, clarify what their feelings are, and emphasize their strengths. Behavioral therapy doesn't foster awareness, but emphasizes learning with positive and negative reinforcement. This is really good for people who have obsessive compulsive disorder. Being exposed to if you know anything about obsessive compulsive disorder, you have these obsessive thoughts that lead to doing actions, these compulsions that help relieve the anxiety related to the obsessive thoughts. And so with behavioral therapy, sometimes you can put somebody in a situation where they may still have the obsessive thought, but they don't have the opportunity to do the compulsion to deal with that anxiety. And after time, they realize nothing happens. And so that behavioral therapy, even though it sounds excruciating at the time, it does over a matter of treatments, helps that person control some of those anxieties related to their OCD. That's just one example of how behavioral therapy can help, but you can see it with attention deficit and hyperactivity disorder and some addictive disorders as well. Cognitive behavioral therapy is one we see a lot, and this is focusing on identifying and correcting distorted thinking. Basically, oftentimes we think of things in terms of maybe negative and a distorted view of self and a distorted view of the world that others don't see. And so if we can change some of that distorted thinking, oftentimes the outlook is improved. So I'm going to have you do a little research on cognitive behavioral therapy. There's also a branch of that is called rational emotive behavioral therapy, and it's based on the idea that our thinking about the world around us leads to our emotional and behavioral distress. So those are irrational thoughts of musts, oughts, and should-haves that can create anger and depression and other things. And I know many of us, maybe even with this pandemic and being isolated, have some of those distorted thoughts going through your head. And so changing or reframing those distorted thoughts into a more positive one can help you cope better. And then contracting is a behavioral technique in which the client and therapist draw up a contract in which both people are obligated to do certain things. And that can be helpful when you have somebody that you're having difficulty with with them maybe participating or doing something that you would think would help reach the goal that they desire, and it provides a reward or benefit system for them. Group therapy is also something that we would see a lot of. Groups can range from 3 to 4 or up to 20, and it provides a way for people who have similar issues to discuss and realize that they're not alone. And also, they can benefit from some of those group therapies can also be a cognitive behavioral therapy and help change the way they're thinking about things. Groups must work through negative content before positive results can surface. You have to have a lot of trust in that group. People need to be feeling like they can open up and share and not face negative comments or negative responses from others in that group. Couples therapy is also a highly effective group model, and family therapy is one that we use as well. And then biomedical therapy is the use and application of biologic and natural sciences. So basically, using both the psychotherapy and also adding maybe a medication or whatnot to help with that issue. Electric convulsive therapy is using a low voltage electric shock that goes through the brain for really short periods of time and provides a small little seizure. And this is really good at restoring chemical balances in the brain, especially those with severe depression, who are not really responding well to maybe some medications, or they are so severely sick that we can't wait. Sometimes that 3 to 4 weeks for the antidepressant to take effect. And so ECT has been helpful in providing stabilization for these kinds of clients. It's only several seconds of seizure activity. I would highly recommend you look into that. Somebody may want to do the research paper on that topic, but looking into how humane it is today versus years ago when we did some of the things you would see in the movies is not how it's done today. So just be aware of that. Biofeedback is a training program in which a client learns to control different physiological things such as a heart rate or their breathing by using monitoring devices. So they kind of talk themselves through, like calming themselves down or slowing their breathing down, and that helps deal with maybe some anxiety type things. So that's another type of therapy. You can use agitation therapy for people who don't respond positively to other therapies, and this is when they're exposed to external agitation from other clients in a controlled atmosphere. And it's basically designed so that the person develops some self-awareness of their own maladaptive behaviors. You can look into that a little bit more. Play therapy, often used for children, and a therapist for them to be able to discuss what's going on in their mind using maybe puppets or dolls or Play-Doh or whatnot. Pet therapy, and then some other ones are occupational therapy, recreational therapy, and creative arts therapy. And if we get to go to clinical, you'll get to experience a lot of these different types of things. Some psychopharmacology. Psychopharmacology is the study of the changes that occur as drugs interact with the chemicals of the brain. A lot of times, most mental health disorders, we don't really understand totally the cause of those mental health disorders, although we're making some headway with some of the science. So we look at patterns, we look at genetics, we look at environmental factors. And then we find a medication that we might want to use. So, the main classification of some of our psychotropic drugs are listed there on page 64. Our anti-anxiety agents, our antidepressants, our mood stabilizers, our antipsychotic agents, and anti-Parkinsonian anticholinergic agents. And we're going to talk more about those in each subsequent lesson when we deal with specific disorders. Just know that the role of neurotransmitters is big when we talk about mental health disorders. And Table 4.1 in your book has a nice discussion of the basic relationship of neurotransmitters to mental disorders. So an example, increases in dopamine we see in patients with schizophrenia. Decreased norepinephrine in depression, and increased norepinephrine in mania. And we see decreased amounts of serotonin with depression and increased amounts of serotonin with mania. So be aware of that, and know that some of our medications are focused specifically on those neurotransmitters. One grouping of antidepressants, such as the SSRIs, which we'll learn about coming up, focus on serotonin itself. just be aware of reading over all of that. And let's see, that goes on page 65 to 66. And then the age-related changes that affect psychotropic drugs in older clients, which is really important information. That's table 4.2 on page 66. All right. And then chapter 5, establishing and maintaining a therapeutic milieu, is a really good chapter, because basically it talks about being self-aware. So I would highly recommend on page 71 learning what empathy is, and genuineness and acceptance. And then doing box 5.1, a tool for self-assessment and awareness. Answer those questions for yourself and see what you come up with. There, box 5.2 talks about the essential components of a therapeutic relationship, and there's a whole listing of it, but empathy, caring, acceptance, mutual trust, honesty, consistency, limit setting, reassurances, explanations, all of those relate to a good therapeutic relationship. The phases of a therapeutic relationship, that should be reviewed, knowing what the orientation phase, the working stage, and the termination phase. You had that before, so make sure you review that. You do need to know that. And then professional boundaries are extremely important in all types of nursing, but especially in mental health care. According to the National Council of State Boards of Nursing, professional boundaries are the spaces between the power of the nurse and the vulnerability of the client. And many of our patients are very vulnerable. And we need to be aware of where our professional boundaries lie. There are no dating relationships between a client on the addictions unit and a nurse. There should not be. That's a violation of professional boundaries. You should not be giving out your or talking to a patient about your own concerns and burdens, because you're there to help them, not the other way around. So be aware of your professional boundaries and read over that information. The Nurse's Challenge, box 5.3, be aware, be cognizant of your feelings and behavior, be observant of the behavior of other professionals, and always act in the best interests of the client. Violations of professional boundaries can occur when there's gray areas that exist and deviations from standards. And then we end up seeing unnecessary personal disclosure by the nurse. We'll see secrecy. That should never be happening. Sexual misconduct, overhelping or controlling, and role reversal are just examples of some of the professional boundaries. And then the next part of the chapter talks about responding to difficult client behaviors. Read over how you deal with somebody who's manipulative. There are certain types of patients that may try to be manipulative. They may try to say, an example would be, "You're the best nurse here on this unit, and I really appreciate everything you do. And I know this is a rule that you have for everybody else, but just this once, do you think you could help me out with this issue I have, and just break this teensy tiny little rule?" That is a manipulation, and clients will quickly see who the weakest link in the system is, and if it's you, you're going to have a problem. So be aware. The limits should be fair, and they should be consistent with everybody. We should not be showing favoritism. Violence or aggression is listed at the bottom of page 75. And I'm going to have you do a little bit more discussion about that in a future assignment. But Maintaining 2 arms length distance between you and the client's always good. Don't touch somebody without their approval, especially if they appear angry. And then don't a call for assistance, don't provoke behavior, and don't enter a room unless well, you shouldn't be entering a room at clinical anywhere. Offer the client time to regain control, to stop the behavior, and change the subject. And then it talks about altered thought processes, hallucinations, and how to deal with those, and then the sexually inappropriate behaviors or aggression. So read over that. I'm sure we'll get into that more in future level. And then last but not least is chapter 7, communication in mental health. Being aware of therapeutic and non-therapeutic communication. You've already learned a lot of that. Review that. But there are some specific speech patterns in mental health that you should be aware of. Blocking, circumstantiality, echolalia, loose association, flight of ideas, neologism, and verbigeration. Know what those are, because you will see that again, hint, hint. So be aware of those specific common speech patterns. Know what are good effective verbal communication techniques and nonverbal communication techniques, how to be a good active listener, and what are non-therapeutic communication techniques. And that should all be somewhat review to you. I hope this was helpful. Thank you.